Good morning. I am Angelo Phillip P from Rizal Medical Center, VRP Medical Center, and Makati Medical Center, and I am tasked to discuss the classification of adult spinal deformities. Widely accepted classification systems are available for adolescent idiopathic scoliosis. However, the same cannot be extrapolated to that of adult spinal deformities. Treatment of adult spinal deformities are guided by several factors such as pain, disability, patient's general health, age, bone quality, and patient expectations. In adolescent idiopathic scoliosis, skeletal maturity and progression of the deformity are the main guiding factors for treatment. There has been an increased interest and advancement in the classification and treatment of adult spinal deformities in the past 2 decades. Many authors have proposed their own classifications to differentiate adult spinal deformities based on description, radiology, symptomatology, and even treatment. To begin with, let us all go back to 2001, where Edward Simmons published an article entitled Surgical Treatment of Patients with Lumbar Spinal Stenosis with Associated Scoliosis. In the study, he classified adult scoliosis into 2 groups based on the presence or absence of vertebral rotation. Type 1 deformities are degenerative lumbar scoliosis with no or minimal rotational deformity, while Type 2 deformities are degenerative scoliosis often superimposed on a pre-existing scoliosis with greater rotational deformity and greater loss of lordosis. He then concluded that instrumentation and correction techniques differ for these 2 types of deformities. Shorter instrumentation procedures are usually considered for Type 1 deformities, while longer instrumentation with sagittal plane correction are necessary for Type 2 deformities. 4 years later, in 2005, Max A.B. published his article Correction of Degenerative Scoliosis of the Lumbar Spine. In his article, he classified adult scoliosis into 3 major curve types based on the cause or natural history of the deformity. Type 1 is a primary degenerative scoliosis caused by degenerative changes in the vertebral disc asymmetry and the posterior articulation. Type 2 is a progressive idiopathic scoliosis which is caused by further development of idiopathic scoliosis that started before adulthood. Type 3 is a secondary type of adult scoliosis, which is divided into 2 types. Type 3A is caused by an extravertebral cause such as static scoliosis or pelvic inclination. Type 3B is a type of bone metabolic disease similar to osteoporotic fractures and scoliotic deformity that is caused by weakness of vertebral bone. In the same year, Frank Schwab wrote his study entitled Lumbar Classification of Scoliosis in the Adult Patient, Preliminary Approach. In this study, he proposed a radiographic classification of adult scoliosis based on lumbar lordosis from L1 to S1 and frontal plane obliquity of L3 in standing radiographs. The inter- and intra-observer reliability of the classification was reported to be excellent. Results from this study showed a significant correlation between end-plane obliquity of L3, L1 to S1 lordosis, and pain visual analog scale. Surgical treatment due to failed conservative management was also noted to increase when there was a decrease in lumbar lordosis and an increase in L3 obliquity. Schwab proposed a new classification in 2006 to include previously established high-impact, clinically significant radiographic parameters. His classification included the type or location of the deformity, a lordosis modifier, a subluxation modifier, and a global balance modifier. It also takes into account patient deformities only in the sagittal plane. In his updated classification, he noted that as lumbar lordosis was lost, as intervertebral subluxation was increased, and as sagittal balance was increased, surgical rates also increased. Decrease in lumbar lordosis and increase in vertebral subluxation resulted in an increased use of circumferential surgery, an increased ODI score, and a decreased SRS-22 scores in patients with Type 4 thoracolumbar and Type 5 lumbar curves. As lumbar lordosis decreased and sagittal balance increased, there was increased use of osteotomies and an increased fixation down to the sacrum. The SRS published a largely descriptive classification system in 2006. This descriptive classification had 7 curve types and 3 ASD modifiers accounting for the regional sagittal, lumbar degenerative, and global alignment, referencing the model of King's classification and Lenke's classification for adolescent idiopathic scoliosis. The system focuses on radiographic features of spinal deformity and enables comprehensive categorization with inclusion of not only scoliosis but also kyphosis. This classification is very reliable but did not encompass clinical considerations such as patient symptoms, related comorbidities, age, or even operative methods and surgical results. The SRS-Schwab classification was published in 2012, considering the relationship between the spinopelvic parameters and the sagittal balance. This system consists of 4 components, which is the curve type, pelvic incidence minus lumbar lordosis modifier, global alignment modifier, and pelvic tilt modifier. This study found out that the health-related quality of life was closely associated to the curve type and 3 sagittal modifiers. Patients with a lumbar curve and a primary sagittal deformity showed greater disability and poorer health status than patients with thoracic curves or a double type curve. Patients with a higher grade of sagittal modifier were also more likely to have spinal osteotomy surgery, iliac fixation, or decompression surgery. This classification reflects the severity of the disease and suggests a guideline for treatment, but there is still no suggestion for specific treatments such as fusion level for the deformity, so surgical management should be individualized. Cesare Faldini proposed a classification system in 2013 mainly directed toward the planning of the most proper surgery for ASD patients. This working classification aims to standardize the categorization of patients and curves and guides in the management of ASD patients. Curves are described as stable curves A or unstable curves B. A-type ASD curves are characterized by an asymmetric facet joint degeneration that consequently involve the lamina, ligaments, and intervertebral discs. These conditions are related to a decrease in the arch of movement of the spinal motion unit and keep a fixed lateral deformity. These are the main determinants of the stability of the curve and determine a segmental or foraminal stenosis with nerve group compression. Stable curves are further divided into 4 categories depending on the main component determining the clinical picture of the patient. In type A1 curves, symptoms depend on facet hypertrophy with foraminal stenosis. In A2, from central stenosis, while the clinical picture in A3 is mainly due to intervertebral disc degeneration. A4 is a combination of these 3. Type B curves are conversely characterized by a developmental degeneration of the facet joints, lamina, ligamentum flavum, and discs. This leads into an increase in the physiologic range of motion of the affected spine. Facet joints might become hypermobile, and cartilaginous surfaces may become fractured. At the same time, ligaments are also stretched. B curves are subdivided into the main anatomic elements involved in the degeneration process. B1 curves are curves with hypermobility due to facet joint degeneration, B2 with instability due to disc degeneration, B3 is in mixed forms, and B4 are curves with more complex cases of sagittal imbalance. Pedro Berjano and Claudio Lamartina did a chart review in 2014 and created a classification system based on the distribution of diseased segments and balance status of the spine. The goal for their system was to identify selected fusions to avoid full curve fusion. This would in turn reduce the surgical risk while maintaining a larger range of motion and reduce the risk of junctional disease and decompensation. They characterize 4 main types: Type 1 limited non-apical segmental disease, Type 2 limited apical segmental disease, Type 3 extended segmental disease, which is apical or non-apical. Type 4 is a imbalanced spine, wherein 4A is sagittally imbalanced and 4B is sagittally and coronally imbalanced. Treatment suggestions were as follows. For Type 1 and Type 2, this can be treated by fusion of a selective area of the curve. Type 3 needs fusion of all the extension of the coronal curve. Type 4 usually needs aggressive corrective procedures, frequently including posterior tricolumnar osteotomies. The Obeid coronal malalignment classification was published by Ibrahim Obeid in 2018 in the article Classification of Coronal Imbalance in Adult Scoliosis and Spine Deformity, a treatment-oriented guideline. In this study, Obeid classified coronal malalignment curves into the following modifiers. Type 1 is a concave curve. Type 1A1 is a concave curve with a thoracolumbar or lumbar main curve. Type 1A2 is a concave curve with a rigid thoracolumbar or lumbar main curve. Type 1B is a concave thoracic or cervicothoracic main curve. Now, Type 2 is a convex coronal curve. Type 2A1 is a convex coronal curve with a flexible non-degenerated lumbosacral junction. Type 2A2 is a convex curve with a rigid degenerated lumbosacral junction. Type 2B is a convex lumbosacral main curve. Based on this different coronal deformity patterns and modifiers, he proposed a novel surgical algorithm to guide in operating these patients. OBEID recommends the following treatment for the different types of coronal malalignment. For type 1A1, posterior column osteotomy and/or interbody release at the apex of the main curve. For type 1A2, a 3-column osteotomy at the apex of the main curve, and for type 1B, a 3-column osteotomy at the apex. For type 2A1, OBEID recommends aggressive scoliosis correction with instrumentation and active control of the coronal malalignment by the patient. For type 2A2, for non-fused interbody spaces, a posterior and interbody release and lumbosacral curve correction using both anterior and posterior instrumentation was recommended. For previous interbody fusions, a 3-column osteotomy at the lumbosacral junction and L5 pedicle subtraction osteotomy was recommended. For 2B, OBEID recommends short correction of the lumbosacral junction with a 3-column osteotomy at the apex of the lumbosacral curve. For our last classification system, James Lin proposed a reliable radiographic classification system for adult idiopathic scoliosis that builds upon the Linke classification for adolescent idiopathic scoliosis. The ADIS classification has 3 components: a curve type, lumbosacral modifier, and a global alignment modifier. The 6 curve types are maintained from the Linke adolescent idiopathic scoliosis classification with a change in the minor curve structural criteria. A curve with a supine radiograph Cobb angle measuring greater than 35 degrees is structural. The lumbosacral modifier was added because the adult's lumbosacral curve stiffened due to age and degeneration. A structural lumbosacral curve is defined as a lumbosacral curve greater than 20 degrees on a supine coronal radiograph. The global alignment modifier was added to determine malalignment in both the sagittal and coronal plane. 40 mm was chosen as to be the cutoff for sagittal malalignment to be consistent with the SRS Schwab adult deformity classification, and 40 mm was chosen as the cutoff for coronal malalignment as it has been shown to be associated worse scores of SRS 22 and the ODI. In conclusion, many classification systems have been developed to try to classify adult spinal deformities. However, there are many factors that affect adult spinal deformities, making it difficult to create a universally accepted classification system. It is of note that none of the classification systems incorporate patient characteristics like older age, higher ASA grade, clinical comorbid conditions, or even obesity. This may probably be used and added to future classifications developed for adult spinal deformities.